Hi everybody, this is Mrs. McDaniels, and this is going to be a quick overview and highlight some points about venous disorders. So venous disorders are going to be problems with the veins, which can cause interference with an adequate return of blood flow from the extremity. So remember, veins are going to be responsible for return of blood. There's going to be three types. We're going to talk about VTE, venous insufficiency, and varicose veins. So venous thromboembolism, which is a VTE, be our first topic. This is a blood clot which forms because of venous stasis, epithelial injury, or hypercoagulability. And see the Varicose triad below here that talks about different things that occur that will cause a blood clot. One type of blood clot that typically occurs is called a deep vein thrombosis. Etiology, this is a great picture. Remember thrombosis, trauma, hormones. This will be your contraceptives, road traffic accidents, operations, malignancy, blood disorders, obesity, old age, orthopedic surgery, serious illness, immobilization, and splenectomy. Clinical picture, you'll typically see the leg look swollen. There may be some leg pain that's increased with walking or standing, visible surface leg veins, warm and redness of the affected leg skin, and fatigue. Lab test to look for substance is called a D-dimer. This is actually used to rule out a blood clot. A D-dimer is a protein fragment that actually breaks down from a blood clot. So if there's elevations, it's indicative of a blood clot. They typically start to slowly break down after they're formed, and like I said, we'll release the D-dimer into the bloodstream. Prevention is always going to be key. Make sure you put your SCDs on your patients. A lot of them don't like it, so when you are doing your rounds, make sure they are properly wearing them, and this is typically ordered from the physician. Movement, get your patient up and moving. Again, make sure safety is in mind. Anticoagulant therapy and thigh-high compression stockings. Some patients, the orders for certain surgeries, especially those that are long, may have an order for both thigh-high compression stockings and SCDs. If somebody actually has a DVT, you want to encourage rest. But more studies are actually starting to show early ambulation to be good. Do not massage the affected limb. You don't want that clot to travel to the lungs. Warm, moist compresses as prescribed. Thigh-high compression stockings. Prepare for possible surgery, the thrombolectomy to actually remove the thrombus. And no SCDs if there is an active DVT. So prophylaxis, again, mechanical will be your SCDs, your TED hose, which are going to be those thigh-high stockings, ambulation, active movement. Pharmacologically, anticoagulants of some form. This could be Levinox, heparin, warfarin, apixaban, one of the anticoagulants. Medication, IV heparin, and remember, giving an anticoagulant doesn't actually break down a current clot, and watch for significant adverse effects. APTT monitoring for dosing. Therapeutic is 1.5 to 2.5 times the baseline. Normal is 30 to 40 seconds. Heparin has a half-life of about 60 minutes. You want to monitor platelet counts for heparin-induced thrombocytopenia, so make sure you know your platelet ranges. Have an antidote available. Do you remember what the antidote is for heparin? Protamine sulfate. and monitor for adverse effects associated with anticoagulant therapy. The biggest complication is heparin-induced thrombocytopenia, or HIT. It causes hypercoagulability. Is suspected if platelets actually decrease by 50% of a person's baseline. An alternative needs to be started. Heparin is discontinued, and the mortality rate is about 20%. So if there is a clot, you'll actually want to use a thrombolytic therapy, which will actually help dissolve the clot that has already developed. It usually has to be started within 5 days of a clot's formation. Administering the medication so it has direct contact with the clot is the most effective. Nursing, you want to monitor for bleeding and educate the patient on bleeding precautions. So if a patient is on this, they shouldn't be using a straight razor, things of that sort. Low-weight heparin, it can be given sub-Q. It is weight-based. Some things to consider: instruct to observe for bleeding precautions, teach the patient about rotating injection sites, teach them to be alerted for any significant bruising. Also, again, make sure you know your platelet counts and, if applicable, a PTT. And again, make sure you know your baseline PTT in terms of what that should be and what is therapeutic. Also, too, in terms of rotating injection sites, you'll see a lot of these patients will have bruising. It's best to try not to give yourself an injection in a bruised area. So APTT and PTT, this is kind of a nice visual that talks about your PTT and APTT and anticoagulant therapy. Some things to be on the lookout for: watch brushing their teeth because it can cause bleeding, nosebleeds, rectal bleeding, and the higher the number, the slower the clot. So that's a good way to remember when we're looking at these lab values. So the higher the number, the slower it is to clot, and the lower the number, the faster it is to clot. So one of the anticoagulants that is used is warfarin. Inhibits the synthesis of the 4 vitamin K dependent clotting factors. Therapeutic effect takes 3 to 4 days. It can be started while somebody is still on heparin. You want, again, to monitor for bleeding. You'll monitor PT-INR. Therapeutic INR is 2 to 3. Ensure that an antidote is available, which is going to be vitamin K. Avoid sources of vitamin K or increase consumption. So basically, if somebody has a diet that's high in vitamin K, they can continue at that same amount, but they should not increase the consumption of it. Teach your patient about bleeding and instruct on bleeding precautions to be needed when they take it. Surgical management, necessary when actually unable to give the patient anticoagulants or a thrombolytic. A pulmonary embolism danger is imminent, or permanent damage to an extremity is going to occur because of a compromised venous drainage. A thrombolectomy, with possible placement of a vena cava filter. This will actually filter, trap large emboli and help prevent a pulmonary embolism. And this is kind of where they'll put that filter in. One brand is like a Greenfield filter. So we're going to talk about venous insufficiency. Venous insufficiency basically occurs secondary to incompetent valves in the deeper veins of the lower extremities, which allow pooling of blood and dilation of the veins. There's an inability of the vein to actually carry fluid and waste from the lower extremities, which will result in swelling, venous stasis, ulcer, and in advanced cases, cellulitis. Some of the risk factors for venous insufficiency is sitting or standing in one place for long periods of time. Also, crossing your legs can cause some issues. Obesity, pregnancy, and thrombophlebitis, which is basically a thrombus that's associated with an inflammation. Nursing care, you want to make sure you elevate the legs 3 or 4 times a day. That will help with the venous return. Elevate legs above the heart in bed. Avoid crossing legs. Remove constrictive clothing. Think of socks, tight boots, things that basically anything that can constrict. Educate to wear compression stockings. That will actually help with the venous return. So when there is intravenous insufficiency, it's going to be about care of any venous status ulcers, and typically that will require long-term management. Wounds that do come about because of venous insufficiency, they will need a wound care consult, and also consult with a dietitian. Because again, if there is problems with venous return, increased fluid, it's almost, again, with the cardiac that we want to try to decrease the amount of retained fluid in the body. So one issue that comes about with a chronic venous insufficiency is varicose veins. You can have bulging veins, leg swelling, change in color and texture, and worst case is your venous ulcers. Lymphedema is another issue of a venous insufficiency. Cellulitis can result because of venous insufficiency. So when we talk about varicose veins, it's basically enlarged, twisted, and superficial veins that can occur basically in any part of the body. A lot of folks will see them in the lower extremities. Risk factors: females, those who are over 30 and work with prolonged standing, nursing in particular, pregnancy, obesity, systemic disease, and it does seem to run in families. Varicose veins, this is a good picture. It shows you how the walls become weakened, the valves do not close correctly, and there causes some inflammation compared to a healthy vein. Findings: usually there's limb pain where there's aching and a feeling of fullness or heaviness in the leg after standing. So a lot of times what they'll do, you can have vein stripping, so varicose vein stripping. These are some really good pictures to kind of show you how that's done. Sclerotherapy, if I could spit that out 10 times fast, where they basically go in, you'll see a before and after. They actually insert a needle into the vein, inject some solution that'll actually help constrict the vein. And so you see how it's swollen, and this will help actually constrict it again. Some related complications: lymphangitis and lymphadenitis, basically either an inflammation or an infection of the lymphatic channel that occurs as a result of an infection at the site distal to the channel, so at distance from it, versus lymphadenitis, which is an infection in one or more of the actual lymph nodes. That's it. If you have any questions, I think that information is pretty straightforward. But again, you know how to find me. Take care.